Asthma is a chronic respiratory condition that makes breathing difficult and uncomfortable. Severe asthma attacks can even be life-threatening. The good news is that there is treatment available for asthma sufferers, and there are innovative new treatments being developed all the time. On this week's Health Talk, our guests will discuss symptoms, diagnosis, and treatment for asthma, so stay tuned. Health Talk is up next. Hello, I'm Dr. Eric Mazer. Welcome to this week's Health Talk. Today we're going to talk about asthma, a relatively common disorder in both children and adults. My guest is Dr. Ming-Ming Lee, who specializes in pulmonary critical care and sleep medicine. Welcome to Health Talk, Ming.
Great, thank you so much for having me.
And welcome to Norwalk. You're a new physician on the staff.
Yeah, just started in late September.
And you have all the latest information on asthma.
Yes, absolutely.
So asthma, we all hear about asthma. We probably all know somebody with asthma. But what is asthma?
That's a great question. So asthma is essentially one of the airways diseases in pulmonary medicine, and it's a result of chronic inflammation in the airways. People with asthma will have typical symptoms of chest tightness, wheeze, cough, shortness of breath that varies over time. So these symptoms are not persistent, but will change over the course of a day or a week.
And we hear about kids with asthma and adults with asthma. Are they different somehow?
There are lots of different types of asthma. So there are definitely there's definitely asthma that affects children, and then sometimes children just outgrow asthma, and then later as an adult the asthma comes back. We don't fully understand why that happens, but it is a phenomenon that we see. And then there are lots of people that just develop asthma as an adult as a result of various risk factors.
And I want to go into some of that. So let's talk a little bit about what do we know, and I know we don't know everything, but what do we know about the causes of asthma? And maybe let's start maybe on the children's side, since I've got little kids, you've got little kids, and we all worry about our kids getting sick. I've got little kids with grandchildren. I want to make that clear.
Yes, absolutely.
But what do we understand? What causes it at all, or what contributes to it?
Yeah, so I focus more on adult medicine, so I don't know the pediatric side as well, I'll say, but there are a lot of different risk factors that can lead to asthma, and in children, there's risk factors like if they were born early or premature and they don't have full lung development. There's also risk factors in terms of environmental exposure. So we know that children growing in urban environments and have exposure to pollution or a lot of secondhand smoke exposure are at an increased risk of developing asthma.
So there's another reason for parents not to smoke.
Absolutely.
If they need another reason, here's another reason.
We have plenty of reasons for people to not smoke. And then in general, there's just a lot of different inflammatory pathways that contribute to the development of asthma, which physicians, if a child is taken to a physician to be diagnosed with asthma, they'll investigate sort of to learn more about what type of inflammation is driving the asthma symptoms.
Now, as I mentioned before the show, I've heard a lot about the hygiene hypothesis and that the immune system sort of needs a certain amount of stimulation during childhood to develop normally. And if you're too clean, you may parenthetically drive people towards these autoimmune or hyperreactive immune systems.
Right.
Is that holding up for asthma?
There's definitely evidence for that, and I think we don't fully understand why that is, but it's definitely been observed that people or children that are exposed to potential triggers like allergens, so dust mites, animal dander, that when they're exposed, they're less likely to develop these
I've read
what
somewhere,
they call
I think that kids who
reactive
have
airways.
pets growing up are less likely to have asthma than kids who are not. Certainly pets can produce an enormous amount of dander. But let's talk about the adults then.
Sure.
Do most adults, have they had childhood asthma before, or is it more common to see an adult that develops it as an adult?
That's a great question, and I think I see a fair mix of the two. It's almost split 50-50, I think, in what I see in terms of people that will say that they were diagnosed with asthma at some point, whether they were a child or a teenager, and they'll mention that they outgrew it, and then suddenly later in their 30s, 40s, even 50s, they come back and they have symptoms that are reminiscent of what they had as a child. And then I'll see adults that have no history of any sort of respiratory symptoms, but they come with symptoms that sound very suspicious for asthma.
Mm-hmm. Now, when I was in medical school, and certainly the earlier part of my career, we were always taught that asthma is characterized by reversible bronchial constriction,
Exactly.
reversible constriction of the bronchial tubes,
Yes.
or bronchospasm. Is that still, and now I know we've learned that inflammation plays a big role in making those bronchi
Absolutely.
twitchy.
Yes.
But is that still the definition of asthma? How do we say you have asthma, or that this is definitely asthma? What are the criteria we use to define it?
So asthma is really a mixture of the clinical suspicion, so based on people's symptoms that they present with and what they tell you, in addition to the testing that we do. So in terms of the symptoms, as I said before, patients will come and mention that they are experiencing chest tightness, cough, wheeze, or shortness of breath, any combination of those symptoms, usually in response to a trigger.
Asthma without wheezing, is that right?
You can have asthma without wheezing.
Go ahead, I didn't mean to cut you off, but go ahead.
Yes, but that is an important point that although it's very stereotypical that people say that the asthma is associated with a wheeze, you can present without a wheeze. But usually the patients will present with these symptoms, and usually it's a response to a trigger. So it might be something like exercise, it could be something like cold air, strong odors like perfumes or bleach, as well as animals, so furry animals or dust, or colds or viruses, things like that that set them off and cause
Sort of
these symptoms to
you're
develop.
There are immune type stimulants, as you said, like animal danders, pollen, but then there are these physical triggers like exercise and cold. So
Right.
it doesn't have to be one or the other.
No.
When someone has, let's say, exercise-induced asthma, do they run pretty much true to form and that's the trigger for them, whereas animal dander may be a trigger for a different person, or do they tend to get mixed?
It can be mixed. So I've seen patients that will present with triggers that are both what we call allergic and non-allergic. And so they will identify that, the springtime is terrible for me, but in addition, when I'm running to catch the bus, I also have trouble breathing. So there's definitely a mix of triggers that people can present with.
So when somebody is diagnosed with asthma in your practice, what do you tell them? What do you tell them in terms of what they should expect, and maybe give us some idea of what kind of testing you do and then how you approach therapy and life with them?
Absolutely. So after hearing a story that sounds suspicious for asthma, the next step is to confirm that there is what you call this hyper-responsiveness of the airways, meaning that the airways will narrow abnormally in response to these triggers.
And the airways, just to point out for folks that don't have muscle tissue in them, that can go like this, literally squeeze down, and that's what causes the weakness and the wheezing and the shortness of breath.
Right, exactly. I like to explain it to patients as though if they're breathing out of a paper towel tube, there's no problem, there's no resistance. But imagine trying to blow very hard through a straw, and then there's a lot of resistance. So it's kind of like that analogy is happening with the airways and the lungs, that when they're exposed to that trigger and then the muscles around the airways contract, it narrows that opening and makes it much more difficult for the air to travel out of it. So in terms of trying to diagnose it, some of the testing that we can do is initial just basic pulmonary function testing, which is the breathing test, to see an idea of patients.
And that's very non-invasive. People breathe into,
it's very
blow into. It's almost like the spirometers people are used to in hospital. You blow into a machine and it traces out your breath.
Right, and all the work for the patient is literally to sit in a chair and put their mouth on a mouthpiece and to follow the instructions of a respiratory therapist. So that's sort of just initial breathing test that we do. And during that test, the respiratory therapist will administer a medication that's called albuterol, which is a short-acting, what we call bronchodilator.
It relaxes those muscles.
Yes, exactly. It acts on receptors on the muscles to try and relax them and open up the airways. And they'll repeat the breathing test to see if there's an improvement in the airflow. So that's one way that can give us a clue if someone has asthma. In addition, there's what we call bronchoprovocation testing, where we actually give people either an inhaled agent or have them exercise, basically something to trigger that hyper-responsiveness in the airways, and then we measure the airflow through the airways to see if there is a decrease in that.
So you're still looking for this reversible bronchospasm.
Right, exactly. And you said a very important word, which is that it's reversible. So people with asthma, they have essentially normal lung function, except when they have these episodes of the shortness of breath, wheeze, and cough. But in response to either a bronchodilator, so an inhaler that relaxes the muscles in the airways, or just with some time, that constriction or narrowing will reverse.
Now we have only 3 minutes left, so if you could just give us some idea of how you treat it. The best way, because I know, well, go ahead. And plus there's some new treatments out there too. So.
Yes. So the mainstay of treatment will be actually based on patient symptoms. So in terms of how severe their symptoms are, how often is it interfering with their daily activities, performing their work, going to school, how often are they having nighttime symptoms. Based on that, we'll sort of decide what are the right inhalers to start patients on. But I will say the mainstay of therapy will be an inhaled corticosteroid.
Which is an anti-inflammatory. Interesting, it's not, the bronchodilator is not the first line of therapy, except perhaps when it's very intermittent, is that right?
Right, exactly.
So you actually are treating the inflammation first.
Right, exactly. So the inhaled corticosteroid is meant to control this chronic inflammation in the lungs. And then on top of that, we may add bronchodilators, which are meant to then relax the muscles and open up the airways. In addition, for treating...
And there are a couple of different kinds of bronchodilators, aren't there?
Yes.
That are being used for asthma now.
Yes. And
the old albuterol type, the what we call beta agonists, but there's some new ones out. Actually, they're not even that new anymore. But
right. So if... Yes, absolutely. And so if someone is on these inhalers and over a period of months we find that it's difficult to control their symptoms, then we will look, if they have the right type of inflammation in their airways, we will look towards what we call biologics, which are these new medications that are actually injections that patients can get on average about once a month. And it basically targets one of the molecules that is very active in this inflammatory pathway and tries to block that to reduce that inflammation and hopefully reduce symptoms.
The new science that we have available with the very targeted therapy.
Right.
There are some ads on TVs that talk about eosinophils.
Yes.
Do you want to just say a few things about eosinophils and asthma?
Yes, so eosinophils are one of the subtypes of the white blood cells, which are I like to describe them as the infection fighting.
So let me warn you.
Okay, so they're one of the infection fighting cells. And so the eosinophils in some patients will be very, very high and is known to be a big driver of the inflammation in asthma. So that is the target of many of the biologics.
And just to sort of wrap up, what percentage of people would you say are well controlled after you do all the things that we can do?
I would say actually a majority of patients actually can be well controlled with asthma. If they take their inhalers, if they try to avoid triggers, so the things that make their symptoms worse, and if they present regularly to their doctors, I think asthma can be a very well controlled, managed disease.
Yeah, I mean, we didn't get a chance, but it can also be fatal. So you've got to be careful, and if you are not responding, see the doctors earlier rather than later.
Absolutely. Don't hesitate to call for help, to either call your physician or call 911 if you're having severe difficulty breathing.
It's never just asthma, because I know that there are deaths for otherwise healthy people of this every year, and unfortunately, we could talk a lot more. We've run out of time. I want to thank our guest today, Ming-Ming Lee, Dr. Ming-Ming Lee, for joining us today on Health Talk. And thank you so much for watching. We just love to hear from you. So remember to share your questions and comments by calling us at Community Relations at Nuvance Health. Our number is 203-852-2250. We'll see you next time.
Well, Thomas, you've got prediabetes. But with more exercise and a change in diet, it can be reversed.
I've tried exercising. It just makes me hungry for bacon.
I love bacon, too. And who really likes to exercise?
Not me.
Me neither.
Nobody. So we're good?
What? Oh, you still have prediabetes. Big time.
When I was 6, I had one thing on my mind. When I was 6, my days were spent playing basketball every chance I could. When I was 6, my dream was to make it to the NBA. When I was 6, my mom had a stroke.
I'm Paul George, and I want you to learn the signs of a stroke fast. F-A-S-T.
F, face drooping. A, arm weakness. S, speech difficulty. T, time to call 911. Because the sooner they get to the hospital, the sooner they'll get treatment. And that can make a remarkable difference in their recovery.
Protect the ones you love.
Spot a stroke, F-A-S-T, fast.
Chronic obstructive pulmonary disease, or COPD, is a chronic pulmonary disorder that results in shortness of breath and progressive loss of lung function. It's a common condition often caused by smoking or occupational exposures. COPD is not curable, but is generally quite treatable. On this week's Health Talk, a pulmonologist will answer the questions on COPD that she most often hears from her patients. So stay tuned to Health Talk. We're up next. Hello, I'm Dr. Eric Mazer. Welcome to this week's Health Talk. Today we're going to talk about COPD, or chronic obstructive pulmonary disease. My guest is Dr. Ming-Ming Lee. She specializes in pulmonary critical care medicine and also sleep medicine. Welcome back to Health Talk, Lee.
Thank you so much.
Ming-Ming.
Thank you so much for having me.
So COPD, we hear a lot about it. There are a lot of drugs advertised on TV about it. What is it?
Yeah, so COPD, as you said, stands for chronic obstructive pulmonary disease, which is an airways disease where there's what we call airflow limitation, meaning there's difficulty with getting air out of the airways or exhaling. And it's a result of being exposed to what we call noxious particles or gases, and the most common risk factor, as you mentioned, is smoking.
So COPD is definitely caused by exposure. You're not born with COPD. Are you ever more susceptible to it genetically, or is it really?
That's a great point. I would say COPD is a disease where it's a meeting of genetics and environment. So there are definitely people that have genetic predispositions that we don't fully understand that make them more susceptible to these environmental exposures.
So just because Uncle John smoked 3 packs a day of Camels for 40 years and he doesn't have COPD, that doesn't mean that I can smoke 3 packs of Camels a day for 40 years.
Exactly.
And don't get me for the Camels are non-filtered. I'll use it generically. But yeah, so COPD is really chronic damage to the lungs.
Yes.
And I know, again, in medical school, we used to talk about the emphysema and chronic bronchitis, sort of as ends of a spectrum. Do we still think of it in those terms? And can you explain what I'm talking about?
Yes, absolutely. We definitely do. So I always explain to patients that COPD is sort of an umbrella term for what we could describe as either emphysema or chronic bronchitis, or something of a mix of the two. Emphysema is really what we describe as a destruction of the airways and really the very ends of the airways and the air sacs, so some of the lung tissue as well. That's diagnosed primarily through imaging and or through tissue, so if it's looked at under a microscope. On the other end of the spectrum is...
Yeah, just to keep lungs are filled with these tiny little air sacs called alveoli. They almost are crinkly if you touch them. I guess if you think of bubble wrap, but smaller bubbles. And in emphysema, you actually lose, a lot of those are damaged and they just become big. And by the way, the oxygen is transferred across from the blood to the air in those little sacs.
You explained it really, really well, yes. And so in COPD, what happens is there's just destruction of those structures, and it results in
less ability to exchange. So I don't mean to talk over you. So that's destruction of alveoli of the spongy lung tissue. And chronic bronchitis is what?
And chronic bronchitis is more referring to, I would describe as predominantly inflamed airways, where people present with a persistent cough. And the definition is sort of based on expert opinion, but they define it as 3 consecutive months of coughing over 2 years. But again, it's just based on expert opinion, and so it's really a clinical judgment.
And so these people usually have exposures. So
usually, yes.
So how can we prevent most cases of COPD? Just take a couple of that, and then let's go into actually the diagnosis and treatment.
Yeah, so I think it's about 80% of patients with COPD smoke. So if people could avoid smoking or quit smoking, that's one of the best ways to avoid the development of COPD.
It's really hard to believe that with what we know about smoking now and the range of illnesses that it causes, that young people will still start smoking. I don't know what they're thinking, but this is another disease that's strongly linked to smoking.
Yes.
It's not just lung cancer.
Right. Yes, it is very strongly linked to COPD. Smoking is, and it's very difficult for patients to quit. But we try to address it at every visit, try to support them, and offer what we can to help them quit.
And from what I understand, quitting is most effective when you are supported by counseling, by drugs.
Absolutely.
It's just simply going home and saying, I'm going to quit is not a very effective strategy, even if you mean it.
Yeah.
Even if you really intend to. It's difficult to quit smoking, isn't it?
It's really difficult. So it really does involve like a multidisciplinary, multifactorial approach to trying to quit, which is, as you said, social support, so going to a smoking cessation program or group, and then using pharmacologic therapy like nicotine replacement therapy or prescribed medications like Chantix people might have heard of, which help to sort of curb the craving for the nicotine.
So that would be your first approach, is stop smoking.
Exactly.
which
That's
is
a
gonna be
really, really important part of care for patients with COPD if they do smoke.
Do a lot of patients sort of get religion when they find out they have COPD and that it's from their smoking? And are people more successful then than they might be when they're young and asymptomatic?
I think it does motivate people when they realize that they have a diagnosis now and that there is evidence of damage to the lungs.
And if you keep smoking, is that your COPD is going to get worse more rapidly than if you don't? That's pretty well known, isn't it?
That is well known, yeah. So in COPD, patients' lung function decline at a faster rate than compared to someone with normal, what we call normal lungs, and who don't smoke. And so if patients continue to smoke, then that decline will definitely accelerate even faster. And so if they stop smoking, it can slow down, so they can make a difference.
And for a while, occupational exposures contributed to
Yeah.
the dust of, I don't know, marble grinders or whatever, people or plumbers with
Absolutely.
asbestos. Well, that's maybe a separate issue.
Right.
Are we better at protecting people now with the respirator masks that people wear in dusty areas, or do people not use them as much as they should?
I think I still would like to see people using them more. Unfortunately, when I talk to patients, I hear a lot that they weren't using the personal protective equipment that
Even
they
though it's
should be
provided
using.
to them or supposed to be worn.
Yeah.
I think a lot of folks are just, again, there's a sense of I'm immortal, it's not going to hurt me.
Right.
And they get used to doing it because it's a little bit nuisancey to wear these things, I guess.
Yeah, absolutely. And I think the damage is silent, so people don't recognize that when they're being exposed to these what we call noxious particles or gases, that there is actually changes going on in their lungs in response to it.
So what's the story, the typical story of a patient who comes to see you, and how do you make the diagnosis?
Yes, so I'd say the typical story I'll hear is that a patient will come to see me because they're starting to know that they're more easily winded doing certain activities, or that the walk that they usually take every day is a little bit more difficult. They may also describe some chest tightness, cough, or that they're bringing up mucus or sputum. And so those are the symptoms that I tend to hear and make me wonder, oh, maybe they might have COPD or some sort of lung disease.
Is there anything that separates COPD from being out of shape? Just being poorly conditioned?
Yeah, so I think one of the more important tests to do is what we call pulmonary function testing or breathing tests. And based on that, we can see if there is an airflow, what we call airflow limitation, which is part of the definition of COPD. And so that is different than someone who's just deconditioned. Someone who's deconditioned will have normal lungs, will have normal lung function. It's more an issue of their muscles not being as conditioned as they should be.
And the pulmonary function tests are pretty non-invasive, aren't they?
Yes, they're very non-invasive. It's a pretty quick test, about 20 minutes. And the patient is coached by a respiratory therapist on how to do the breathing maneuvers. But all the patient has to do is sit in a chair and put their mouth on a mouthpiece and follow the respiratory therapist instructions.
And so this is a pretty simple test. So if there's any question, it's pretty easy to do this test, and you get a lot of information from it, don't you?
We do, yeah. We sort of get an idea if there's difficulty with the exhalation part of breathing, so the airflow limitation, if there's any trouble with them getting air fully in, which could be a result of what we call trapped air in the lungs. If patients aren't able to get all the air out, then it makes taking that next breath very difficult.
I think people may find that almost counterintuitive, because I can breathe. How can I be trapping air in my lungs? But they don't realize that the lungs are elastic, and they normally help to squeeze that air out. And when it loses that elasticity,
It gets stuck.
You can't
Yeah.
get the rest of the air out all the way
Right.
out. So we actually see on an x-ray with these big dark lungs that are filled with air and pushing down on the diaphragm.
Yeah.
So when you have someone with COPD, how do you treat it?
So a lot of it is based on their symptoms and if they've had what we call exacerbations or flare-ups of the COPD in the past. So based on those two together, we will decide what are the right inhalers to put the patient on. Sometimes if patients are not very symptomatic and they present relatively early on and they haven't had exacerbations, it might be just an as-needed inhaler, which works to what we call bronchodilate or open up those airways by trying to relax the muscles that surround the airways to try and open them up. If they have more severe symptoms or if they are having flare-ups of the COPD, then we'll prescribe what we call maintenance or controller inhalers that they take every day, no matter what.
Okay. How do you differentiate COPD from asthma? Because they're sounding a lot similar, exacerbations, shorter breath. It sounds like the causes could be quite different, but how do you separate those two?
I will say that it actually can be difficult to differentiate the two and that you can see overlap between the two. But in general, asthma is an airways disease where people have normal lung function, where they have periodic episodes of worsening of symptoms, and that hyper-responsiveness of the airways, so the abnormal constriction of the airways that is reversible, and that's asthma. In COPD, the airflow limitation is what we call fixed or permanent, and so even though we prescribe these bronchodilators, we can't fully open up the airways like they were before.
So there may be some hyper-responsiveness, but they don't get back to normal when they're resting.
Exactly.
And how about deterioration? Do all patients with COPD follow some linear course, I shouldn't say linear, but some course of steady deterioration, even if they're treated?
It's very individual. So I've seen patients that do have a relatively steady decline in their COPD, and others who actually are very stable for many years. I think a lot has to do with if they also develop exacerbations or flare-ups of the COPD, then sometimes what happens is they'll have an episode where they get very sick from the COPD, and they recover, but they never get back to where they were before they were sick.
And very sick. These folks have a high risk of pneumonia, presumably, and bronchitis and bacterial, because they're not clearing their secretions as well.
Right, they're more susceptible to infections.
So these are also patients, presumably, that are at higher risk for getting things like influenza or pneumococcal pneumonia. They should be vaccinated if they're not already.
They should definitely get their vaccines, yes.
And I think people don't fully appreciate how important those preventative measures are.
Yeah.
So what do you see as the future of COPD? For a while they were doing, I guess, lung reduction surgery. What's at the cutting edge right now?
Unfortunately, I think we don't have a lot cooking right now. COPD is an area where we have a lot of inhalers, but I think we have sort of been a little bit limited. And so we're still hoping that we find other treatments that can help these patients. But I would have to say that unfortunately, medicine is sort of lagging in that area, unfortunately.
Are lung transplants ever an option in these folks?
They are an option, but I think it has to be in the right patient and it has to be very selective.
So this is really an important illness. I know it's very common. We certainly see a lot of that in the hospital. And what the patient can do, there's a lot that they can do to prevent. Prevention is the best therapy for that, isn't it?
Yes, absolutely.
And unfortunately, we've run out of time. I want to thank our guest today, Dr. Ming-Ming Lee, for joining us on Health Talk. And thank you for watching. We love to hear from you, so remember to share your questions and comments with us by calling us at Community Relations at Nuvance Health. Our number is 203-852-2250. We'll see you next time.
When I was 6, I had one thing on my mind. When I was 6, my days were spent playing basketball every chance I could. When I was 6, my dream was to make it to the NBA. When I was 6, my mom had a stroke.
I'm Paul George, and I want you to learn the signs of a stroke fast. F-A-S-T.
F, face drooping. A, arm weakness. S, speech difficulty. T, time to call 911. Because the sooner they get to the hospital, the sooner they'll get treatment. and that can make a remarkable difference in their recovery.
Protect the ones you love.
Spot a stroke, F-A-S-T, fast.